Well, the biological subtyping is so critical because for neurodegenerative diseases, all of the labels that we have used are there essentially coming from clinical means. We see somebody at the bedside and we say, based on a checkbox that I'm using to determine if someone has a disease or another, a person fulfill the criteria of one disease, for instance, Parkinson's, and we just simply say that is the final diagnosis. And that is really a bit of a placeholder diagnosis. The correct diagnosis in the future, we hope, would turn out to be what is it, the underlying biological abnormality that's there for that individual. And we have for years acknowledged that not two people with Parkinson's, for instance, have the same condition, not two people with Alzheimer's have the same condition, and yet haven't acted as if we mean it when it comes to deploying molecules for therapy that have really wonderful mechanisms that target a variety of different biological disruptions. Well, we need to connect those biological mechanisms, these therapies target, to those individuals whose biotype, whose biological subtype is rendering them vulnerable to benefit from these therapies. And that's something that I think in the future we have to do. If a company has a therapy that's developing that would enhance, say, a certain aspects of the mitochondrial function, you want to have people in the trial that are enriched for that specific mechanism, where that is not a downstream problem, but an upstream generator of the abnormality in those individuals, so that then the chances of success are magnified. We need to admit that there are many biological reasons for which someone could develop Parkinson's, and therefore splitting here is going to be basic. We lump for most of these trials, and we have nothing to show for that lumping. For disease modification, splitting is really critical, and the biological splitting is essential if we are to get to the future of precision medicine for our patients.